Comprehensive, relevant, and insightful conversations about health and medicine happen here on MedStar Health DocTalk. These are real conversations with physician experts from around the largest healthcare system in the Maryland, D.C. region. Abdominal pain, heartburn, and fatigue might be the symptoms of overeating, indigestion, or acid reflux, but they can also be the result of stomach cancer. It's a sneaky cancer with symptoms that could be insignificant and easily dismissed. That's a common theme among survivors of stomach cancer who often say they ignored the early signs of the disease when it's most treatable. And it is treatable. Is it curable? We're going to get answers to that question and more during this week's episode of MedStar Health DocTalk. Let's meet our guest physicians. Welcome MedStar Health gastroenterologist Dr. Walid Chalhoub and medical oncologist Dr. Reetu Mukherji at MedStar Georgetown Cancer Institute. I'm your host, Deborah Schindler. Doctors, thank you for sharing your expertise with us today on DocTalk.
Hi, Deborah. Thank you for having us.
Happy to be here, Deborah.
Stomach cancer, also known as gastric cancer, occurs when the DNA in stomach cells mutate, causing the cells to grow out of control and form a tumor in the lining of the stomach. Is that a fair description?
Pretty much to a certain extent. It is pretty accurate. Just like any cancers, the DNA does mutate, and those cells start growing out of control, and they do form tumors or cancers. But specifically with gastric cancer, it's a very difficult cancer to screen for. With, for example, colonoscopies, there's science behind it. Hundreds, if not millions, of patients have been studied over multiple decades on how you screen for colon cancer. There's newer guidelines now on how to screen for pancreatic cancer as well, just because a lot of data has been coming in for it. For gastric cancer, it's the screening remains very tight because the patients that we do screen usually have hereditary disorders, people with hereditary diffuse gastric cancer, or patients with prior histories of gastric cancers, or larger polyps within the stomach that were found incidentally when you were doing upper endoscopy. So that's why the screening guidelines aren't very, very clear still, and they're not very broad amongst the population. So there's no specific age where you start screening for them, at least in America, and different populations have different risks to develop them, and that's why there's not one screening mechanism to screen them all at the same time.
Absolutely. I think, many patients wonder, what is a cancer? How does it start? And kind of what you alluded to earlier, it is when really one cell, something goes wrong, the DNA becomes mutated or altered. And essentially at the level of the gastric epithelium, there's just growth, abnormal growth of these cells until it becomes less and less like normal gastric tissue until it's something abnormal. And cancers can grow into be, diffuse things that spread throughout the stomach wall. They can grow to be masses, and then, if given enough time, they can also start to spread locally and flick off little cancer cells in the bloodstream that can go to lymph nodes and potentially other organs farther away.
Why does this happen with the mutation of these cells in the stomach? Is it genetics? Is it environment? I was surprised to read that cigarettes play a role sometimes in stomach cancer. I mean, we expected it with lung cancer and maybe esophageal cancer, but stomach cancer was a surprise to me.
I think there's a couple different, reasons for why someone may develop a stomach cancer, and it's probably, a combination of the things that you've mentioned. So some of the known risk factors are things like smoking and alcohol. These are things that essentially cause stress and inflammation at the level of the cells in the stomach, and these can lead to mutations and alterations. We also know that there are certain bacterial infections that can increase the risk of stomach cancer. For instance, H. pylori, which is a bacteria that can grow in the stomach. Absolutely, there are hereditary conditions that can predispose people to developing these stomach cancers, not just stomach cancer, but maybe even other cancers in other parts of their body. We even know things like diet can contribute to the risk of stomach cancer. So high salted foods, foods high in salt, even foods high in nitrates, and processed red meats have been linked to the development of stomach cancers as well. And really, it probably causing some form of inflammation and irritation and DNA damage through different mechanisms that lead to the development of cancer.
Just to piggyback on what Dr. Mukherji was saying, they don't go from zero to cancer right away, right? So there's multiple stages of how the cells change in the lining of the stomach. They start with something called intestinal metaplasia, which increases the risk of them becoming cancerous. And then that metaplasia can change into dysplasia, and then that dysplasia changes into high-grade dysplasia that eventually changes into cancer. All those levels of how people start getting this metaplasia are affected, just like Reetu was saying, in terms of an environment, if you're talking. For example, in Japan, they have such a higher risk of gastric cancer because of the salted foods and the nitrous they eat with the sushi. They do have a higher rate than anybody else in the world. You were talking about smoking. There's a community in China that Dr. Fleischer was studying, specifically for esophageal, because esophageal and gastric cancer are very similar. And that community used to cook with coal and be around coal a lot and be around fumes. So those were also seen, I think, up to 70 times higher than the regular population in developing gastric cancer. So the environment really, truly does affect your propensity and you being prone to getting it. So it's not so genetics for sure, and then the environment for sure, and then how you treat your body also. That is very, very important to keep in mind. One thing I just want to say, just because gastric cancer is one of those cancers that can slowly progress without you feeling it, and just like when you first started, Deborah, talking, say a lot of people just let those symptoms go unnoticed, a little epigastric pain, a little reflux here, a little early satiety there, and the cancer itself has a lot of space for it to grow as well, because the stomach is an open pouch, right? So a lot of the times they grow and grow and grow and grow and grow, and then by the time you diagnose them, they're already big enough that they've already metastasized and it's too late. So it is very important to always take your symptoms very seriously if you are feeling them, because if people start losing weight or abdominal pain or start feeling nauseous, have trouble swallowing, if it's, for example, more of a proximal cancer in the stomach, more towards the end of the esophagus. People, for example, start seeing blood in their stool, or people who start to get anemic. Those are all patients we have to look out for. Patients with ulcer-type pain, very stabbing pain in the stomach, those are patients that we need to be very aware of in general, as also patients who might have a higher risk or need to be screened earlier, need to be looked at earlier.
At what point do you suspect cancer that you want to further and maybe do an endoscopy?
Most of them are asymptomatic because there's no mass yet. This is just the cellular level just changing. Mm-hmm. So these are the patients, specifically with the intestinal metaplasia, those are the patients you want to jump on. First and foremost, make sure that you get a very, very adequate upper endoscopy, get something called mapping of the stomach. So you take biopsies from all around the stomach, and the stomach is divided anatomically into different places, and you make sure that you biopsy all those places, and then you figure out where exactly those cells came from, because cancer obviously doesn't just grow in the whole stomach, right? It grows in a part of the stomach. Most of them grow in a part of the stomach. So you need to figure out where those cells are metaplastic or where those cells are transforming. Is it on the greater curvature of the stomach, the lesser curvature of the stomach, towards the distal stomach? So that's why if you can identify where these cells are changing earlier, that's how it's much easier for you to go back every year or 2 or 3 to make sure that that specific area didn't change and that specific area didn't develop a growth or those cells didn't change more, because those are the cancers that you can catch earlier and have them treated, resected, and then obviously you cure a patient like that.
I mean, how would a patient know to ask for mapping? Under what circumstance would they be coming in to see you? And then
so that is a very important one. So they do come in with the symptoms that I was saying. Epigastric pain is a big part of it. Okay, nausea is a big part of it. They come in, you take a look at the stomach. Usually metaplastic areas in the stomach are redder. They have some erosions to them. So they present with these symptoms. But again, most of them don't present with any symptoms, and they're getting EGDs for reflux. And you go in and you find this red area or this nodular area in the stomach. So a lot of them are incidental as well.
Okay, another thing that you said I wanted to ask about was that you use the term polyps. Is that interchangeable with tumors, or is that also like, as with colon cancer, is that a precancer in the stomach?
Yes. So different types of polyps in the stomach are a little different than polyps in the colon. Most polyps in the colon are something called a tubular adenoma, and these are precancerous lesions that, if left in place long enough, will develop into cancer. Gastric polyps, there's different types of gastric polyps. There's something called a fundic gland polyp, which is totally benign. So those are polyps there, but you don't have to take... most people have innumerable ones, and then you don't take them all out. You just sample some of them. And if you do prove that they are fundus gland polyps, and most of them are less than 1 centimeter in size, if you do sample some of them and they do come out to be fundus gland polyps, you just let that patient be. You don't have to send them for genetic testing or to oncologists or for gastrectomies or what have you. But there's other types of polyps like hyperplastic polyps as well. They're not tumors either. They're not cancers. But if they do grow, again, more than 1 centimeter in size, recent data has shown that these polyps, if they do grow, they tend to have some potential for malignant transformation. So those polyps that are bigger than 1 centimeter in size that are hyperplastic need to be resected completely because they can put you at a risk of developing stomach cancer. So in short, gastric polyps are very different than stomach polyps because their pathology is different. But you can also have adenomas in the stomach as well. Those act very similar to colon polyps, and those are the ones that mostly turn into cancer if not resected.
When we talk about polyps, correct me if I'm wrong, these are kind of findings during endoscopic procedures, but really biopsying them and taking a look microscopically with what's going on in the polyp gives us an answer as to whether it's benign or if there's something more aggressive going on, like an invasive malignancy. So, a polyp can be something completely benign, but it can also, sometimes when it looks abnormal, bigger or more aggressive endoscopically, taking a biopsy and making sure it's nothing more than a benign lesion is important.
Are you the physician who would take that biopsy, Dr. Chalhoub, or is that refer that to a surgeon? Okay.
No. We take the biopsies. We do most of the resections if they're benign polyps. There are some different types of treatment for gastric cancer, specifically early gastric cancers, and these are newer types of treatments called ESD, endoscopic submucosal dissection, because, again, with cancer, just like I was, like both me and Dr. Mukherji were describing, these cells go in stages and phases before they become cancerous. So if, let's say, a portion of the stomach was metaplastic and went into dysplasia.
Let me pause you a minute. Metaplastic.
Yes.
Can you define?
Metaplastic is the early transformation of a cell from normal into. So let's say normal is 0 and cancer is 5. Metaplastic is the first transformation at level 1. Okay. Level 2 would be dysplastic. Level 3 would be high-grade dysplastic. And then level 4 would be early cancer. Level 5 would be cancer.
Got it. And then there's different types of cancers.
Many different types.
Oh, we don't need to name them all here. But what are the most common types of cancers?
Yeah, so when we say stomach cancer, there are many different types of cancers that we could be alluding to. And it is so important to understand what specific type of cancer it is that we're talking about, because our treatments and the prognosis vary so much based on the subtype. So really the most common cancer when we're talking about stomach cancer is adenocarcinoma. This is cancer that starts in the glandular cells, the glandular tissue of the stomach. This is somewhat in the same family of the common colon cancer, breast cancers that you hear out there. These are cancers that start in glands and those organs. So stomach adenocarcinoma really is the most common one. But certainly there are other types of cancers that can arise. There are things like neuroendocrine tumors that are very different from adenocarcinoma. They arise from different cells. They behave differently. Treatment is different. We can even see things like lymphomas, which are cancers that arise in the cells that form our immune system, our lymphatic channels. So it's very important to get a biopsy when we're trying to identify what it is that we're dealing with. I think a lot of our discussion today will be tailored towards stomach adenocarcinoma, really the common one that we see for Stomach Cancer Awareness Month. And to really confirm that's what we're dealing with, we need a biopsy and tissue confirmation.
I have a list here of symptoms that most of the materials that I read in my research came up with. Feeling bloated after eating, feeling full after eating, nausea, heartburn, indigestion, blood in the stool, vomiting, weight loss for no reason, stomach pain. Now, if a patient comes in, we've already established that this could mean a lot of different things. When do you start to suspect stomach cancer, and what's the first step in diagnosing a patient?
There's all these symptoms that you were describing. Some of them are called alarming symptoms. And alarming symptoms are things like unintentional weight loss, things like blood in the stool, things like early satiety. Those are very alarming symptoms. So those, you actually jump on it right away, and the first thing you want to do is an upper endoscopy. Mm-hmm. All right. There's other things, just like some epigastric pain, some discomfort, some dyspepsia, some nausea. You don't have to do an endoscopy right away. So those are the patients that you treat with DPIs, meaning antacids, for like 2 or 3 months, and then see them back in clinic and see how they're doing. If they're still through maximum dose therapy still not doing good and they're still having these symptoms, then you go ahead and get an endoscopy. But specifically patients who have alarming symptoms, you don't have to wait that time. Weight loss, early satiety, blood in the stool, vomiting blood, those are patients that you want to, patients who are high risk, patients with a family history of gastric cancer, patients with a family history of other types of cancers, patients with a known history of H. pylori, for example. Like all those patients are at a higher risk and you don't have to wait so long. You just go ahead and do an upper endoscopy on them.
If someone has more pronounced symptoms, does that mean that they are in a more advanced cancer stage?
Advanced symptoms are very subjective matter, and depending on the location of the cancer too. So just like I told, because stomach cancer has space to grow, if it's more on the proximal side, meaning more in the upper stomach, you tend to feel it less than if it's more towards where the stomach empties into the intestine. Because if it's closer to where the stomach empties into the intestine, then that tumor or that mass is going to start to grow and start to block the food passing. And that's when you start getting the sense of early fullness, the sense of vomiting, and those are alarming signs. So it is very subjective again, but those patients, it depends on where the cancer is. Usually that's how quickly or how acutely they do present.
Kind of in line with what Dr. Chalhoub is saying, the symptoms related to stomach cancer sometimes can be specific, but many times are very non-specific. And there's so many different things that could cause these symptoms of early satiety, pain, acid reflux, dyspepsia symptoms. And it can kind of be hard to tease out without taking a direct look what exactly is going on. Now, like he mentioned, where the location of the tumor is, some people can just have a localized tumor higher in the stomach and be very symptomatic compared to someone with one farther away, not quite blocking off the food pipe and the esophagus. But when we talk about advanced cancer, meaning cancer that may have spread outside of the stomach to other organs, this can also be very non-specific, but some patients can have symptoms such as pain in certain parts of their abdomen farther away. If things have traveled to the liver, they may have lymph nodes or swelling in certain areas of the body that look larger. And sometimes when stomach cancer can spread to the lining of our abdomen called the peritoneum, we can develop swelling and fluid that builds up in the belly. So very, non-specific symptoms, but with very advanced cancer, it can be a little bit more than just the typical nausea, vomiting, dyspepsia, but maybe also pain in different parts of the body.
I'm sorry, what's dyspepsia?
Yeah, that refers to symptoms related to a lot of acid buildup and acid reflux. So this can be in the way of burping, belching, pain or a burning sensation in the throat, in the chest, and even maybe a metallic or a bad taste in the back of the mouth. So symptoms related to
indigestion.
A lot of indigestion. Mm-hmm. So the first step in getting a diagnosis, you mentioned the endoscopy. Let's go down the list then. We got a physical exam, the endoscopy. What's the tumor markers test?
So tumor markers can refer to a few different things, but we can start with talking about blood tumor markers. So there are certain blood tests that we can look for proteins that are expressed by some of these cancers aberrantly or in higher levels that they can spill out into the blood. An example of this is a marker called CEA or another one called CA19-9. So these are blood tests that look for protein levels. But it's very important to know that these are not very specific. They do not diagnose cancer in and of itself. They can just be signs that maybe something is going on. They can also be elevated if there's inflammation or infection. So again, not very specific for cancer. So tumor markers in the blood are something that we commonly test when someone is first diagnosed, but they are really not the most important part of the diagnostic algorithm. The way to diagnose is if you have symptoms, you take a look. If there's a mass, you biopsy it and you figure out is it a stomach adenocarcinoma. And we can talk a little bit more about the next steps in the way of staging, which are important. And what we want to know next is how advanced is it? How far has it traveled, or is it just where it started? And the way we look at that is by doing CT scans, which look at the chest, abdomen, and the pelvis. If we find that the cancer seems to be localized, even if it's to some of the nearby lymph nodes, we often will send patients back to somebody like Dr. Chalhoub to do something called an endoscopic ultrasound, which is very similar to the endoscopy that first happened to get the biopsy, but this time we're using an ultrasound and imaging probe to try to get a better understanding of how deep through the wall did the cancer travel and is it in the nearby lymph nodes. So this helps us better stage cancers, how locally advanced may they be.
And the patient is asleep for the endoscopic ultrasound, correct?
Yes. So endoscopic ultrasounds are just like a regular endoscopy, but just the actual endoscope itself has a little ultrasound machine right at the tip of it, very, very tiny one, and it has that ultrasound capability and capacity. And just like Dr. Mukherji was saying, so once you do diagnose them, let's say somebody did get an upper endoscopy in the community and they found this mass, and then they biopsied the mass, and the mass came back as an adenocarcinoma, for focusing on specifically on adenocarcinomas. The CT scan is very important to stage to see if it's gone anywhere, because if it's already gone to different parts like the liver or the lungs, or so you don't really need an EUS, because an EUS is very focused on local staging and to make sure that this is resectable, or to make it resectable, because you can give them chemotherapy and radiation therapy to shrink the tumor first and then get them to a resectable stage. So CT scans are very important, the first step in making sure that these patients are either in the yes or in the no of getting treatment. Or even in the yes or in the no, they all get treatment, but in the yes or in the no of them becoming surgical candidates or not, like intent to cure, pretty much. Just like you were asking, yes, patients are completely asleep. The risks of them are just like any upper endoscopic procedure. You go in with the probe itself, the ultrasound probe, and you figure out where the cancer is. And then our GI tract is pretty, I'll explain this very quickly. Our GI tract is, the actual stomach itself is comprised of 5 different layers. Something called the deep mucosa, then there's the submucosa, there's the superficial mucosa, deep mucosa, submucosa, muscularis, propria, and then the actual outside lining. And these 5 linings are very important because the level of invasion into these layers dictates what the type of treatment is. So an EUS is very sensitive and specific. The ultrasound is to show us how deep this mass does go into the layers of the stomach. So, and then these are divided in something called a T stage. So there's something called a T stage, an N stage, and an M stage. I'll explain these to you as well. These are very technical, but a T stage goes by how big the cancer is and the level of invasion into these different layers of the stomach wall that I was talking about. And then the ultrasound can also look at the nodes. You can specifically see if there's any nodes around the actual cancer cell, because having nodes versus not having nodes is also a huge critical point in dictating the treatment of what the next step should be. And then with metastatic disease, EUS is usually not good, because metastatic disease is when the cancer goes to separate parts of the body. And again, like I said, an EUS is very focal, very targeted test. It just takes a look at this mass itself and if it's really deep and how deep it is into the stomach wall.
When you say having nodes, do you mean having nodes show up positive for cancer?
Correct.
Okay.
Actually, see a lymph node on EUS means that it's pathological. Usually lymph nodes do not appear on ultrasound, just by the definition of you actually being able to visualize the lymph node. You don't even have to biopsy it.
Just seeing them tells you that there's cancer?
If you already have proven cancer, right,
Okay.
on endoscopy, that's when you go for the ultrasound.
I see.
So you already know you have cancer. Any node, if you do see it on ultrasound, is considered a positive node, because usually you never see nodes on ultrasound.
Which indicates that it has spread.
Correct. Into the nodes doesn't mean that it has gone everywhere in the body.
But that will tell you that you need to treat this in a certain way.
Correct.
Which
And this is very important information that I give to Reetu, and Reetu tailors their treatment according to what I find on ultrasound. And Reetu, you can tell them exactly what.
Yeah. So Dr. Chalhoub alluded to the different layers in the stomach wall. So if there's very superficial mucosal, kind of the first layer involvement, and the cancer hasn't spread beyond that, hasn't spread deeper, and it hasn't spread to the lymph nodes, sometimes a GI doctor like Dr. Chalhoub can just do a local procedure like a resection, an endomucosal resection, to try to cure somebody of this very early stage cancer. Now, if the tumor we find has traveled deeper through the wall, through the muscle wall, even before the muscle wall, just what we call the submucosal layer, even if you don't see nearby lymph nodes, the risk that the cancer has traveled to the lymph nodes increases significantly. So while an endomucosal resection, a local surgery or procedure, may not be enough to cure, that's when we send patients to a surgeon, and they'll do a bigger operation, something called a gastrectomy, where part or the whole of the stomach comes out. But not only the stomach, they will also take out the lymph nodes and the tissue around the stomach, given that there's a higher chance, even if we don't see it, that the lymph nodes have become involved with cancer. Now, at the time of staging, if we find either the tumor has gone deep through the wall of the stomach, or if we see it, lymph nodes have been involved up front, we call those cases locally advanced cases. locally advanced stomach cancer. And the risk of recurrence after surgery is higher with this stage. And so in these cases, often I will see these patients or somebody in the medical oncology group, and we are offering patients some form of perioperative treatment. So this is typically in the form of chemotherapy given for 2-3 months before, and then even given again 2-3 months after surgery to improve the odds of cure, since these patients are high risk. So that's why it's so important upfront to fully stage patients, make sure it hasn't spread farther away, see if the lymph nodes are involved, how deep through the wall has it traveled, because that will really dictate the optimal treatment for patients for cure.
When you go and you biopsy a patient, have you found them usually to be in a later stage because of what we talked about earlier with the symptoms being so random?
Yeah, so I'll tell you this. Most cancers that are diagnosed from patients feeling them are already T3s. Meaning that they've already invaded. Stage 3? Yeah, stage 3. Correct. Usually very early cancers are incidental cancers because you don't feel them. Unless like somebody was very vigilant, had a lot of heartburn or had a lot of epigastric pain, and then their gastroenterologist has very low tolerance to treatment first and then them coming back. Those are the early stage cancers. So ESCs are called, early stage cancers. And those cancers are usually less than 2 centimeters in diameter. They, just like Dr. Mukherji was saying, they don't tend to involve the muscularis layer. Those are patients who can get a very deep resection called an ESC or a deep EMR, where you go inside and you tunnel and you dig them all out. Those are patients that mostly are found incidentally rather than them feeling it.
I did read that in some cases, genetic or molecular tests may be done on the biopsy tissue. Which cases are selected for this, and what information can be gleaned from these tests?
Absolutely. So molecular testing is incredibly important in that when we diagnose stomach cancer. And I will say, most often we are testing it very routinely in patients who have advanced disease. So we're talking about patients where unfortunately cancer has spread to the liver, lungs, farther away, or they may not be candidates for surgery in that case. And the reason it's so important, so this is doing molecular testing, DNA analysis, protein analysis on a tumor sample. The reason it's important is because we know that if certain patients have certain mutations or certain markers, they are eligible for therapeutics that target those markers specifically that have been shown to have survival benefits. And so sometimes these therapies that are targeted could be used with chemotherapy. Sometimes they're used alone. There are many different targets that we can talk about. So especially in advanced disease, when we're talking, even if it's palliative treatment, very important to test. Actually, the first treatment we give people with advanced disease depends very highly on molecular testing. So often I'll ask Dr. Chalhoub to go back and get me some extra tissue because we need enough tissue to run these tests, and we need to get it on all these patients up front. Now, while a lot of these therapeutics are approved and have shown survival benefits in the metastatic or advanced disease setting, we are now starting to move some of these therapies and test them in earlier stages of cancer. So we're talking about the curative setting. So for patients who are going for surgery right now, the standard of care for locally advanced disease or resectable is, as I mentioned, some chemotherapy before and after surgery for the vast majority of patients. The question is, should we start using some of these targeted therapies in that setting, adding it to chemotherapy before and after? Now, there have been some studies that have looked into this. Really, there's no approved agent right now that we add to chemotherapy, but there are some promising results from studies using things like immunotherapy or targeted therapies such as directed towards HER2. So in my practice, I like to know molecular profiling in all the patients that I see, absolutely the metastatic patients who are not going for surgery. But even now, for patients who may be surgical candidates with locally advanced disease, there are certain markers I want to know because we do have data that actually giving immunotherapy to a certain subset of patients, this is the minority of patients, but these patients can do much better than with chemotherapy. And this subset, what we're talking about are patients who have this marker called microsatellite instability, also known as mismatch repair deficiency. And just very briefly, what this means is these patients have tumors that make a lot of mutations. They're very abnormal. And when we give immunotherapy, which are drugs that pretty much activate our body's immune system to try to recognize cancer and go after it, We think these tumors with a lot of mutations are better recognized intrinsically by our body's immune system, so immunotherapy works especially well here. So it's important to know, even in patients who are surgical candidates, if they have this marker, because we have some phase 2 data that supports giving immunotherapy rather than chemo in these cases.
And immunotherapy, that falls under the targeted therapy category. Is that an infusion? Are they pills? Give us a little, what a patient or what somebody might expect if they were told it's a good option for them.
So I guess let me go back a little bit and, what is chemotherapy? Chemotherapies are drugs. They can be pills. They can be IV drugs that essentially damage DNA. And cancer cells are rapidly dividing DNA to grow. So chemo works by damaging that process and essentially killing cells so they can't divide, cancer cells. Immunotherapy is very different. There's actually different types of immunotherapy. There are some immunotherapies that essentially block signals that allow cancer to hide from the immune system. There are other immunotherapies that are essentially infusions of immune cells, whether it be your own immune cells or others. But specifically when we talk about immunotherapy and stomach cancer here, the ones that we have approved in advanced disease, these are drugs called checkpoint inhibitors. The way I describe it to my patients is I say, your cancer is smart. It has a way that it hides from the body's immune system. It puts up a little marker on the cell surface that says, don't kill me, don't eat me, I belong here. And immunotherapy are drugs, checkpoint inhibitors are antibody drugs that go and block that don't kill me signal. And essentially that unmasks cancer from our body's immune system, allowing the body's immune system to go after cancer. So that's an example of checkpoint inhibitors. Those are drugs that we use in stomach cancer today. And the drugs that we have today are infusion therapy. The common one, the ones that are approved are nivolumab and pembrolizumab, and these are infusion therapies given in the infusion center through the IV. We do not yet have a pill form of this.
Okay, so you had mentioned that some people weren't candidates for surgery, and that's probably bad news, I would think. Who gets surgery and who doesn't?
For patients with localized disease, even if it's locally advanced, even if it's traveled to the nearby lymph nodes, and if they're strong enough and the surgeon says, hey, I think I can take this patient to surgery, we are trying to get those patients to surgery to cure them. So localized, locally advanced disease, the goal is to try to cure. Now, when the cancer has spread outside of that local area, if it's gone to the liver, the lung, or even a lymph node farther away, unfortunately, that's when we think that the cancer has become systemic. It's learned how to spread through the blood vessels. It's not contained anymore. And surgery is very unlikely to cure these patients. So stage 4 disease, metastatic disease for the most part, unfortunately, is incurable.
A lot of patients who would be surprised, just once they describe to them what the outcome of a surgery is, sometimes opt out of it. Although you can tell them this is curable, but they just don't want to deal with no stomach, living without a stomach. Any stage that we stage on EWES that's more than a T1A, which is early stage 1 cancer, needs something called a diagnostic laparoscopy, where we do go into the stomach, very minimally invasively, inflate the stomach, take a look around, make sure there's no distant metastases, because gastric cancer cells love to go to the omentum. They like to live inside that cover of the intestine. So we take a look, make sure there's nothing there, and then those are the patients that we feel comfortable for them to get a partial or a total gastrectomy, as well as neoadjuvant chemotherapy with Dr. Mukherji.
I'll just add that maybe the last staging thing that we might use, in addition to the CT scan, the endoscopy, the endoscopic ultrasound, and the diagnostic laparoscopy, sometimes we will also get a PET scan, which is a different type of imaging. And PET scans light up bright where there's a lot of activity, where there's a lot of cell growth, cell turnover, so cancer tends to light up bright. And this is another way to just take one more look and see, is there cancer anywhere else besides locally? Now, there are certainly limitations to all of these diagnostics, and PET scans may not always pick up things nicely at the level of the lining of the abdomen, the peritoneum, and that's when things like the diagnostic laparoscopy are very helpful to take a more granular, closer look and make sure we're not missing any small amount of cancer. And so we're choosing the right patients to go for a big operation like a surgery.
And I'm glad you actually brought up PET scans for distant metastatic disease. If somebody gets a CT, the initial CT that we were saying, once you get endoscopy, you take the biopsies, they're cancer, then you get a CT. If the CT doesn't isn't really sure about distant metastases, these are patients that also benefit from a PET scan as well.
And ultimately, if we are left at a point where we're not really sure, we always try to get a biopsy, because it's just so important to make sure we fully stage people properly, to not take off, the option for surgery in patients who may be eligible.
And just one thing regarding the lymph nodes, I just want to make sure that it's clear. So lymph nodes that are adjacent to the mass and you can actually see them, those are the ones that don't need biopsy. But let's say there's another lymph node that's retroperitoneal or something that's abnormal that did show on a PET scan or on a CT scan. Those are nodes that you have to go after and you have to biopsy to make sure that they don't have cancer involved.
What do you mean by retroperitoneal?
Just anatomically in the stomach, there are some nodes that are not just adjacent to because lymph nodes in our body are distributed in specific areas or concentrated more in specific areas. The ones that are concentrated next to the stomach is the retroperitoneum. That is an anatomic place. If one of them is larger, you would want to go after it, even if it's not adjacent to the actual lesion in the stomach itself.
Yeah, Deborah, I think here it's kind of, especially if the lymph node is felt to be outside of the field of what a surgeon is going to remove, which would technically make someone maybe stage 4 or advanced metastatic rather than locally advanced. Those are the lymph nodes that we would typically want to go biopsy and make sure.
And then you would refer them to perhaps for, you mentioned the gastroectomy.
The gastrectomy, correct.
For stomach removal. And
yes.
I know we don't have a surgeon here to talk about that, but once that stomach is removed and the stomach cancer in theory is gone, is that to say that the patient is cured? And what has been your experience with long-term results for patients?
I mean, that is an excellent question. The most important thing is if you do go in for curative intent and it's taken out and they get their chemo and I do my job correctly and Reetu does her job correctly and everybody on board, patients can't just go skipping along for the rest of their life. They have to be on a specific regimen of surveillance. And this is how you keep these patients healthy and happy. These cancers tend to recur because if somebody's genetically predisposed to cancer, they got it in the first portion of that stomach. The fact that they actually have a gastric cancer puts them at a higher risk of them developing it later again in life if they were cured the first time. So it doesn't mean that it's just that coda that you're going to have that one lesion in your stomach and you're done. We're talking about patients who have just part of their stomach taken out, because not all patients have all the stomach taken out. The margins, most of the times when they do take them out, the surgical margins are negative, and that's how you know somebody is cured or on the course of getting cured. You take it out, there's nothing in the surgical margin, they get chemo, they get a CT scan, 6 months later, everything's negative, they have a PET scan. If they go 5 years and nothing's there, I guess a cure is 5 years, right, Reetu? Or
typically, we'll follow people up to 5 years. We say the majority of relapses or recurrences, if it were going to happen, it typically is in the first 2 to 3 years. It can even happen up to 5 years. But then it becomes exceedingly rarer if cancer is still there to recur after 5 years. So 5 years is typically the mark that we use. I think
in those 5 years, you need to make sure that you survey them. Upper endoscopy, CT scan, possibly PET scans as well.
Just kind of going back to your point about, surgery, is it done? It's not so simple, because as Dr. Chalhoub was saying, there's different risks of recurrence or the fact that there might be microscopic residual disease out there. So the decision for, if someone goes for surgery up front, we thought they had an early stage cancer, they go for surgery. It's still very important to look at the pathology and maybe have them see a medical oncologist afterwards as well, because some patients, when we do surgery, we find that they had more than actually what we first thought with the staging scans. And if that's the case and they didn't receive any chemotherapy before, they may be candidates for chemotherapy after. But for some very early stage cancers, they may just need surgery and that's it. And as Dr. Chalhoub mentioned, we recommend routine surveillance scans in the way of CT scans every few months, endoscopy. And I actually started incorporating a technology called circulating tumor DNA. This is something that our field is pretty excited about. It's not quite made its way into our guidelines for stomach cancer, but we think it's a very strong prognostic tool. And when we talk about biomarkers, this is essentially a blood test that you just draw blood from a patient and you look for a signature, this DNA signature that was in their original cancer. And essentially, a ctDNA test says, yes, I detect this person's cancer DNA in the blood, or no, I don't. And there are many different assays out there, but what we learned is that if you have a positive ctDNA test, you detect patients' cancer in the blood, that's typically bad news. There's 95-100% chance that there's still some cancer out there, even if you can't see it on a scan. So what do you do with this information, especially if the scans don't show anything? That's really the question that our community has. We know that we've identified a high-risk situation. They've completed all their standard of care therapy. There's still something small floating out there. We just can't see it. What do we do? How do we treat it? Do we treat it? Or do we just wait until we see cancer come back on a scan, which is our standard of care today? So, at Georgetown, we actually have a clinical trial treating in that setting where we find these high-risk patients using this novel technology. And many of us are using ctDNA in clinic to just give extra information about, is there still something out there, even if our scans can't show it? And there's different strategies that we might use to treat in that setting, although we really don't have guidelines to tell us what to do yet there.
Is there a connection between stomach cancer and other cancers like esophageal or colorectal?
I mean, stomach cancer, we used to kind of treat esophageal GE junction stomach cancer similarly. We thought they were all on the spectrum of the upper GI tract, but we do appreciate now that they are very distinct entities. In fact, they're molecularly different. They behave differently. But there are some stomach cancers that live a little bit higher up in the stomach, closer to the esophagus, the GE junction. They're treated fairly similarly. Now, when you talk about is there association with esophageal cancer and other cancers, I think typically we're thinking about maybe hereditary syndromes there, where there may be something passed on in a family that predisposes an individual or family members to develop multiple cancers. And there are certain syndromes, for instance, Lynch syndrome. This is a syndrome that, people can be predisposed to colorectal cancer, endometrial cancer, pancreas cancer, even gastric cancers as well. So there are certain things we look for in family histories, and if it rings off any bells, we send patients to genetic counselors to get genetic testing done. There's also other syndromes like Li-Fraumeni syndrome with different mutations that are passed on in the family that can predispose people to not just stomach cancer, but also cancer. So especially if we see someone with multiple cancers or family members with that, we will think about something like a hereditary syndrome. I think otherwise, if somebody had kind of the same risk factors that apply to stomach cancer as they would to something like colorectal cancer, or even a nasal cancer, there's some overlap in the risk factors for people that develop nasal cancers, esophageal cancers, stomach cancers. For instance, smoking, those risk factors can predispose people to multiple cancers at once.
The only one I would also add, something called Peutz-Jeghers, is also a syndrome that if you do have Peutz-Jeghers, you are at an increased risk of developing gastric cancer, pancreatic cancer, colorectal, I think, and those are three main ones. But the most important one that we do see a lot of is Lynch syndrome. Lynch syndrome has a direct correlation with gastric cancer and colorectal cancer, and these are connected together. So if somebody has Lynch syndrome, they're on a schedule of getting regular upper endoscopies and colonoscopies at the same time to make sure that they did not develop cancers in either their stomach or their colon.
What advice do you have for people who suspect that they might have a stomach cancer?
Patients with alarming symptoms. So weight loss is a big one. Increased satiety is a big one. Family history is a big one at a young age. A history of a non-healing ulcer that they've been scoped before. They said, this is just peptic ulcer disease, and it's just non-healing, and it's just going over. It's been 3 months, and you're putting on maximal therapy. And those are patients that you want to make sure you get a CT scan, you get an EUS, just to make sure that these ulcers are not deep, and they're a type of adenocarcinoma that's very aggressive. So those are the patients that I want to scope. So non-remitting symptoms despite maximal therapy is a big one for me to go ahead and do them, and all the other risk factors that we talked about too.
Just to add to that, fortunately, the incidence and even the death rate from gastric cancer has been decreasing over the past few decades, but there has unfortunately been an alarming trend for a higher incidence of younger onset GI cancers. We talk a lot about this in colon cancer, but it's also a trend that we're seeing in stomach cancer. So, sadly, we are seeing younger and younger people in the medical oncology clinic with these cancers, and they certainly would not think to go screen for this, especially as we don't have screening guidelines and often have very nebulous symptoms. So, just encouraging patients, if they have symptoms that are non-remitting, like Dr. Chalhoub said, risk factors in the family, meet with your primary care doctor, have a discussion about your symptoms, the longevity of it, family history, and, low threshold to see a gastroenterologist and discuss whether you're a candidate for something like an endoscopy to take a closer look. But there are, unfortunately, disproportionately affected populations in the United States who are diagnosed with stomach cancers. We see higher rates in Hispanic population, Black population, even Native American and Alaskan. So there are some groups that we need to think about a little bit more when they come to us with symptoms, whether it be the primary care, the GI doctor, or even, medical oncology, to just see if they might be higher risk and warrant a closer look.
It's a complicated cancer, really, with a lot of variables and no clear-cut path to treatment, it seems. Between you, you've probably had hundreds and hundreds of patients. So reflecting back on your cases, is there one that stands out that would give other people significant hope?
Actually, yes. I do have multiple patients that do stand out. Patients who had early cancers that were diagnosed, resected, and they're 5 years out, and they're completely asymptomatic, very happy, and went on to lead normal lives, after their diagnosis. One thing I would really keep any patient with is to make sure that never to take symptoms lightly. A lot of patients, specifically older men, tend to push a lot of their symptoms out of the way. And those are the patients who unfortunately come to you and they're already at a stage where you can't do anything to them that would extend their life. Making sure that they don't take symptoms lightly, making sure that they don't smoke, making sure that they watch their diet, making sure, those are all things that are preventable, that you can prevent. You obviously can't prevent your genetics, but the things that you can prevent, I think they need to be very vigilantly aware and to go ahead and do.
Yeah, in my clinic, I see patients not just early stage, but also late stage. And so more than just one example, but one that pops to mind is, I have a very elderly gentleman who came in with stomach cancer. It was localized. Wish we could go to do surgery and cure him, but he was not a surgical candidate. He was too old, too frail. He got molecular testing done, and he was in that 5-10% of patients that had that marker that suggested he might do well with immunotherapy. So he's 7 months into immunotherapy, and the tumor has really melted away. He might be cured. It might be there microscopically, we don't know, but good quality of life. And, I think what the purpose of that is to really highlight, getting that consultation, getting the molecular testing done, because you don't know what other options you have besides surgery, radiation, chemotherapy that you may be eligible for. And truly characterizing the tumor opens the door for some patients, not all, for some of these other therapies. And on the other side, in advanced disease, we certainly have a lot of room for improvement when cancer becomes metastatic. The median survival, we want to see numbers better than a year or 2 years, which is where we really are with some of our different subtypes. And some patients do better than others, and the molecular testing is so important. I have an older gentleman who almost 90, and he has good quality of life. He doesn't know, he doesn't feel that he has metastatic cancer, but he's doing well with stability on a targeted therapy. Everybody's case is different, and I think just keeping, options open, getting the consultation, molecular profiling done, seeing what there's a chance that you may benefit from certain targeted therapies, and you don't know until you take a look at the molecular data. And finally, clinical trials, right? We need to get patients on clinical trials. Every drug we have today came from a clinical trial where we tested it and showed a survival benefit. And, I have some patients who have gone on trials and they've done well. They don't work for everyone, of course, but, those are really the cases that stick out to me. I think very important to be considering that in, really any stage of the disease.
Well, you guys know your stuff, and I've been really enthralled to speak with you. I
think this is really good. I think patients, it is a lot for them to take in at these meetings. We have multiple ones with them, but podcasts like this and other resources online, I think really will help for people who are looking for more information.
Thank you.
Thank you. You are pretty inquisitive, I have to say.
But it's
so nice.
It's very interesting.
So nice.
Likewise, thank you so much. And thank you for giving me so much time. We've been talking with gastroenterologist Dr. Walid Chalhoub and medical oncologist Dr. Reetu Mukherji. For more information, go to medstarhealth.org/cancer.